Good morning to all. Today we will be discussing about the neurological manifestations of rheumatoid arthritis. Rheumatoid arthritis is a deadly disease which affects 0.92% of the adult population in India. The annual incidence of rheumatoid arthritis is about 20 to 40 cases per lakh population. It is more common in females. Male patients with positive rheumatoid factor are more prone to develop extra-articular manifestations. The exact cause of rheumatoid arthritis is unknown. Multiple factors like genetic, environmental, hormonal, immunological, infectious factors may play significant roles. It is estimated that the overall mortality of patients with rheumatoid arthritis is 2.5 times higher than the general age matched population. The various neurological manifestations are either in the peripheral nervous system or in the central nervous system. The central nervous system, the seen manifestations of rheumatoid arthritis are cervical myelopathy, seen as vasculitis, meningitis, progressive multifocal leukoencephalopathy, hyperviscosity syndrome, stroke. The peripheral nervous system involvement include entrapment neuropathies like carpal tunnel syndrome in the hand, tarsal tunnel syndrome in the foot, and various forms of peripheral neuropathy like distal sensory neuropathy, sensory motor neuropathy, mononeuritis multiplex. It also involves the muscle causing either disused atrophy or steroid induced atrophy and myositis. Coming to the cervical spine, it is the third most commonly involved joint in the rheumatoid arthritis. There are three categories of abnormalities. They are atlantaxial instability, superior migration of odontoid, and subaxial subluxation. These may occur together or in various degrees in in the same person itself. Now, atlantaxial joint, why it is preferentially involved in rheumatoid arthritis is because it is also a synovial line joint and it is susceptible to the same proliferative synovitis and instability because of the disease process. And the most common type of atlantaxial joint instability is the anterior type. The more common risk factors for cervical spine involvement are the predilection for cervical spine involvement in RAR in female sex, patients who are having positive rheumatoid factor, patients who are in long-term corticosteroid treatment, peripheral joint erosions, patients presenting at a younger age itself with having a longer duration of disease and high markers of disease activity like high ESR, high CRP, and the higher disease activity score. So, this is the first vertebra. It is the atlas, where these are the facets where the base of the skull attaches, and this is the space for where the odontoid process from the C2 comes comes and locks here, and this is the transverse ligament of atlas. And these are the normal vertebra which has the body and which has the articular surface for interlocking with the top vertebra. And in this image of lateral view, you can see the normal atlantodense or the odontoid process and the vertebral distance, which is usually less than 3 millimeter in adults and less than 4.5 millimeter in children. And this is the example of rheumatoid arthritis causing anterior atlantoaxial instability with anterior subluxation, where there is a subluxation of the C1 with the C2. There is a pannus formation here, and the spinal cord is getting compressed here between the pannus anteriorly and the posterior arch of atlas. So you can see this is the atlantodense interval, and this is the superior migration of the odontoid into the foramen magnum, where you can see that the odontoid process of the C2 has gone deeper into the foramen magnum and causing compression of the spinal cord. And this is the subaxial subluxation X-ray showing multiple ladder-like pattern, step ladder-like deformity because of the subluxation of each vertebra. So this is the patient who is having joint pain and uh, difficulty in walking for the past 4 months. Patient had had dragging of feet while walking and weakness of both his upper limbs, predominantly distal upper limbs. On examination, patient had spasticity in all four limbs and exaggerated reflexes, and plantar was extensor bilaterally. Patient had also had impaired joint position sense in his both little fingers and toes. An MRI of the patient showed evidence of odontoid migrating into the foramen magnum, and there is a T1 isointense, T2 hypointense lesion over the C1, which which is like which is the pannus, which is causing compression and causing uh, myelopathy, which is evident as a hyperintense, faint hyperintense T2 signal in the upper cervical spinal cord. This is the axial section where of the cervical spinal cord, where there is a compression by the pannus predominantly over the left half of the cervical spinal cord. So these are the manifestations of rheumatoid arthritis with corresponding to cervical spine. Coming to the prognosis, the cervical involvement increases with the duration of rheumatoid disease as previously told, and many patients with pain and radiographic criteria for instability do not develop neurological sequelae. So even though the deficit the disease is high and imaging shows a more prominent disease, the neurological deficit is only seen in only 7 to 34% of the cases. And even though majority of the cases seem to have a good prognosis, 10% of the patients with atlantoaxial instability may die from brainstem compression. And this is all, most of the cases have been post-mortem identified because of the sudden death in rheumatoid arthritis. Coming to the other manifestations of rheumatoid arthritis, the other one is CNS meningitis, which is a rare form of manifestation, that there is aseptic meningitis. In this, patients may present with headache, altered sensorium, and occasionally fever. It is less common without the other extraarticular manifestations of rheumatoid arthritis. It usually is present in already seropositive rheumatoid arthritis patients. In this example, we find that there is a thickening along the pachymeningeal, and there is enhancement in the left frontal and the right anterior cranial fossa. There is also tentorium thickening because of a contrast thickening because of meningitis. Here in the spinal cord also we notice that there is a thickening of the pachymeninges in anterior to the spinal cord. In usually the CSF picture of rheumatoid arthritis in aseptic meningitis shows elevated protein, normal, usually normal or sometimes lower level of CSF glucose, and either monocytosis, increased cell count, or pleocytosis. But very rarely the cell count may also be normal in aseptic meningitis of rheumatoid arthritis. And this is an example of a progressive multifocal leukoencephalopathy. So rheumatoid arthritis patients who are under treatment and under immunosuppression develop progressive multifocal leukoencephalopathy due to JC virus infection. About the PNS manifestations of rheumatoid arthritis, There are the entrapment neuropathies, like the carpal tunnel syndrome compressing the medial nerve, the tarsal tunnel syndrome compressing the posterior tibial nerve, the Morton's neuroma, where there is a fibrous tissue formation around the nerves and the lateral and medial plantar nerves causing compression. There are also multiple varieties of forms of peripheral neuropathy involvement like pure sensory or distal sensory predominant neuropathy and mononeuritis multiplex, and also autonomic neuropathy. Musculoskeletal involvement is very common in rheumatoid arthritis, and in particularly with muscular involvement, there are multiple types, which it could be either diffuse atrophy, or it could be due to inflammatory myositis, or it could be due to rheumatoid cachexia due to high disease activity. It can also be due to steroid induced myopathy,